it. Oh.
I thought you were going to put me this way. That's fine. No, not that. No, it's possible, you know. I know. They go like going to the nose. What kind of lenses like those? No, I thought you were going to be filming it. Yeah, I'm ready. Like how it's
My night was our ready to repair because the equipment is like 63 months.
oh, yeah. Oh, yeah.
Two more or two more?
But you think why not?
Yeah.
This is.
See it? Yeah.
Oh, right.
So they started testing more people that huge. Oh yeah. Looks as though, I don't know whether it's just the same, it's as though measures are having some sort of effect. If it falls, it's still upward, but it's more gradual. Just go by other codes, just so you can say.
Mouth here.
Evening all. Thank you again for being with us. This evening we're confirming that we have diagnosed today an additional 235 cases of Covid-19 to bring us to a total of 1,564 since the beginning of our experience with this disease. We're reporting that there have been sadly 2 additional deaths, one in relation to a female with an underlying condition from the east of the country, and another, a male, also from the east of the country, and bringing the total thus far to 9 deaths. And we'd like to take the opportunity to extend our condolences to the families and friends of these 2 individuals. Our more detailed breakdown of cases, the HPSC report as of midnight, Monday the 23rd of this week, of 1,164 cases shows that 55% of them are male, with the median age again at 45 years. 305 of them have been hospitalised, that's 26% in total, with 39 up to that point admitted to intensive care. 283 of them are healthcare workers, and 559 or 57% are from Dublin, 133 or 11% from Cork, and 49% of that 1164 cases are episodes of community transmission. We have seen through our contact tracing data a reduction, which I've emphasised to you yesterday, of 20 per case approximately 2 weeks ago, dropping to 10 per case approximately 1 week ago, and down now to about 5 contacts per case, again giving us encouragement in terms of the compliance with social distancing that we have in place in the last 10 days or so. Across the world, there have been 413,467 cases diagnosed, with 18,433 deaths across 196 countries. In Italy, the total now stands at 69,176 cases diagnosed. In Spain, 39,673. In Germany, 31,554. In France, 22,307. And across the United Kingdom, 8,077. And just bear in mind different testing strategies applying across some of those countries. Just in terms of highlights today, this booklet was published and will begin to be with the very considerable assistance of An Post, and the postmen in An Post, having waived the fee that they would normally be paid for the distribution of such things, will distribute to every household in the country a booklet providing basic information in relation to a lot of aspects of coronavirus, the symptoms, the signs, what to do in the event of experiencing symptoms, information about self-isolation and so on, to provide for the public basic information to empower them and to enable them to respond as we would wish. So we're happy to take any questions that you might have now. Richard.
Tony, Richard Chambers from Virgin Media News. I'm just wondering at this point, not looking for any specific ages of people involved, but is there an age profile for the 9 patients who have died so far?
We don't have that and haven't calculated that at this stage, but in the not terribly distant future we'll begin to make that data available to you.
Just tell us when?
It'll be next week, I would say early next week when we begin to do that.
I'm sure you've heard across the day reports from GPs across the country who have been flooded with concerned patients about the change in the testing criteria. Have you any message for GPs who have been basically run out the door with people calling them today concerned about whether or not their testing would be going ahead?
So I'll bring Dr. Henry in a second. We have a message, we conveyed it in a letter that we wrote to all GPs through the representative organisations and with the considerable assistance of the ICGP and DIMO yesterday. Further information in the form of detailed information in the form of FAQs will be made available again through the representative organisations to all GPs in the country this evening. So we'll support the GPs to ensure that they have all of the information that they need in relation to the case definition and the changing case definition, which is part of routine response in a pandemic situation. The case definition in this context we've changed 4 or 5 times in line with either the advice of the ECDC or in this case now alignment with the WHO case definition. Maybe Dr. Henry might add in terms of some of the work we've been doing over the course of the day to work with GPs.
Just to add, we were engaging with GP representatives yesterday before the case definition and throughout the day from 7 o'clock this morning, to make sure that they're enabled and they have full information as to how they can pass on the proper advice to their patients. And that's where this belongs, that patients who have questions about how it pertains to them, whether they're waiting for a test or whether they feel that they may need a test, the proper way to do that is directly through their GP, and that's how we intend to make this communication clear. So we're confident that the discussions we've had with GPs today will give them the information they need to give any inquiries, to field any inquiries, and to give the proper advice to patients.
One more from me then for the moment. Michael McBride, your opposite number in the north, has said that he believes the number of true cases of coronavirus in the north is now many thousand. Is there any such estimate here at this point? Is that something you would likely make a call on at this point?
I wouldn't project a precise number. We know that we won't necessarily pick up, no matter how efficient our case detection methods, every case that might occur in the community. And we know that we've had obviously an experience where we're now saying about 49% of cases are community transmissions where we're not able to identify the links. We have different testing strategies in the two countries. So our efforts here have been very much focused on identifying in as much as we can all of the cases that arise and encouraging people to come forward for testing. We've had a significant response from the public, as we've detailed to you, and we can set out again. But we've diagnosed in this country 1,500 and just over 1,500 cases across what's now something in the region of 24,000 samples, and laboratory testing results haven't been given back to 18,000 people in this country. So we do have different testing strategies and have had heretofore in the two parts of the island.
Would not be plausible to say, though, or it's a plausible hypothesis, that if you have 49% of all cases confirmed are from community transmission, that the number of cases is much higher than is the current?
I'm not going to suggest to you that we have found all 1,564 cases in the country. We know there are more cases out there. We know that means that the message to the public has to be that if you have symptoms to suspect that this could be the disease, we've tightened up the nature of the symptoms that we're raising awareness of, particularly among GPs. And when people come to GPs looking for information or looking for guidance in relation to their symptoms, we've now given a tighter case definition, as we explained to you yesterday, to GPs to enable them to target and focus the testing. It's clearly possible and likely that there are more cases out there than we have found, but we still, in our message to the public, are clear that we want, with this case definition, to try to focus on catching every case that we can for the purpose of detection and instituting our public health contact tracing arrangements and our messaging to the public around self-isolation. That's our strategy. As to the possibility of further cases, I'm saying absolutely that is the situation. There will be cases in the population that we have not detected, and that's why we continue to recommend to people to follow the public health advice that we have, that this infection could arise spontaneously in the community. Colm, do you want to add anything to that?
Good evening, Michelle Hennessy from the Journal.ie. Can I ask a quick question about the two patients who have died of the virus? I know in relation to the female in the East that she had an underlying condition. It's not listed on the press release whether the male had an underlying condition. Can we take it that he didn't?
We haven't been notified that there was an underlying condition, and we usually would be if there was. So some of the cases so far have had reported underlying conditions that have contributed, and some have not.
Okay. Mm-hmm. Do you have any figures, any new figures on the numbers of people who've recovered?
So we don't have that information at this point in time. We expect to be in a position very shortly to be able to give you data on recovery and all of the outcomes that are important in this particular disease. And the work we're doing now with both our modelling group and with the HSE and with our hospital system is to try and build us a capacity to be able to report that kind of information in real time. We expect to be there very, very shortly and in a position to give comprehensive real-time reporting in relation to those kinds of pieces of information.
The new numbers that we're seeing over the last week are fairly static. It's around the 200 mark, and people, yourselves included, were expecting in the early days for it to be higher than that. Are you worried that members of the public will become a little bit complacent now that they're seeing the numbers not jump up as high as they would have expected?
No, I don't think we see any real sign of complacency. We have a lot of information that give us a sense that, first of all, people are worried. First of all, people are worried that there has been a change in that, and we've seen people get a little more concerned, which we understand. We have had, and I shared this information with you yesterday, a significant response to the change in case definition we made about a little over 10 days ago, when the travel component was removed, that in and around 20,000 cases a day, or people rather a day, sought testing because they believed they might have this condition. And that's not obviously a sign of complacency, it's a sign of substantial concern on the part of the public, which we understand. Our view is that many more people than are ever likely to have this particular disease have been seeking testing, well beyond a level that is either necessary, feasible or sustainable in terms of a testing strategy. And as I said yesterday, were we to test to that scale, we'd be well ahead of any other country in the world in terms of testing. We think it isn't necessary for our public health management, just as we say in respect of an individual, it isn't necessary for a test result in order for a person to know the important measure to follow, which is to self-isolate for 14 days, and that the contacts who live with you in your house, the individuals who you share your house with, restrict their movements for a similar period. And as we recommend for the population now, a very substantially reduced profile of general movement, that additional burden, if you like, for people is not that different than the recommendation for the general population in terms of significantly cutting down their movement and trying to work from home and so on as part of our general now significantly tightened measures in terms of social distancing. We don't think that the let's say the reduction or the difference. So when I initially gave you some figures about what we might expect out over a week or so, we were, I think, predicting that we might have something in the region of 350 or so cases by the end of last week. We haven't seen that, but I think it'd be too early for us to conclude, even though it's good that we've had fewer cases reported. It'd be too early for us to conclude that this is a result of our social distancing measure. If I was to look for an encouraging sign in that direction, I'd be pointing more towards the reduction in the number of contacts that we've seen for each of the individual cases that the contact tracing teams are finding. That has reduced significantly over the period that the social distancing measures have been in place, and that tells us that the population is responding well to the measures that we have in place.
Just one last question from me. We heard from the health minister today of a couple who had coughed in his face and who seemed to find it quite funny. And there are also anecdotal reports of youths engaging in a game similar to that. There are obviously people who aren't taking the public health advice seriously. How do you reach those people?
Well, we've had very considerable support from yourselves in the first instance in helping us to get our message across. One of the most effective means, if you like, of responding to this disease is to get good quality, trusted information out to as many people as possible through the media, through social media, and through other environments. And we'll continue to work with you and to work to try and enhance our communications with more and more targeted strategic communications to different groups using different media over the course of the coming weeks and months, to try to ensure that we learn, if you like, first of all, from the impact of the messages that we have issued in different groups, and on the basis of our understanding of that, to use that analysis to continue to target through different media the messages to different groups of the population. I was standing beside the Minister when he was asked that question earlier on, and when he spoke about that experience, and he responded very clearly and emphatically, and that it was important that the public understand the significant nature of these illnesses and the risk that it could well be a member of the family of somebody who's involved in some of those kinds of activities that you've mentioned, who might be impacted by the disease. Our message to everybody in the population is to understand that while this is a mild disease for 80% of people, for a portion of people, this is a significant and serious disease that can lead to critical illness and death, and the severity of which is greater than we would experience with something like flu.
Thank you.
Hi, Tony. Shane Beattie from News Talk. The change in criteria, case definition that you announced yesterday, a lot of people talking about this today. What do you say to people who think that in some way this is, or Ronan, you can take this either, that in some way this is going to mask the figures, that this is a way of not reflecting the true picture of COVID-19 in this country, because now you need 2 symptoms and also need to be in the priority group. People feel this is a way of, for want of a better word, hiding the true figures.
So, excuse me, the primary purpose of testing in the first instance is a public health purpose. So it's to help us to understand the extent of
this disease across the population so that we can ensure that we are contact tracing and ensuring that it doesn't spread on from one person to the next. So key to that, in fact, is testing as many people as we can. And that has been the approach that we've taken throughout. And it's why, in fact, the testing per capita in Ireland is up there with the best in the world. We're in the top quartile in terms of countries in the world, in terms of the number of tests we've done for the size of our population to date. So the attempt at all times has been to test as many people as possible, and that remains our strategy. Our strategy hasn't changed in terms of testing as many people as possible. But what we've said over the past 24 hours is that clearly the vast majority of people that have been tested over the past couple of weeks with widening of the case definition have tested negative. And so what we've done in response to that is to tighten our case definition to essentially make it more likely that the people who we are testing, that we're picking up the people that actually have the disease, and therefore we can target the resources of the health service more effectively at contact tracing all of their contacts. I mean, ultimately our plan is to continue to increase our testing capacity. Our plan is to test as many people as possible, but clearly in the short term we're prioritising particular groups, those who are most vulnerable to this disease, our healthcare workers. But as I say, over the coming weeks we will continue to ramp up and test more and more people.
And Tony, pictures today on social media of construction sites right across the country with workers not being very physically distant. How does that sit with you?
So I think construction sites vary from one another, and it can be a challenge in every construction site for if you like, the managers of those construction sites to ensure that it's possible for people to distance themselves socially. In many construction sites, it is possible, and in fact, sometimes the challenge can be not just in terms of the construction site and how it's constructed, but perhaps the personal behaviour. And without wishing to criticise people, I completely understand. You can observe it around the streets here, where there are substantial construction sites, where there is good quality, if you like, compliance in terms of social distancing with during work periods, but often during break times you see quite close engagement between individuals. So personal behaviour is part of this as well. The understanding and part of construction.
If you're lifting in a window, it's very difficult if you have 3 or 4 people to lift in a large window. They're not going to be 2 metres apart. I'm just wondering, how does it sit with you to see workplace scenarios where people aren't 2 metres apart?
So what we're going to do is to continue to work with industry, to work with the Health and Safety Authority to ensure that we help workplaces to understand what compliance will look like and what compliance will work like. But we'll keep all of these kinds of things under review as we've done since the beginning. And we think that there are construction sites where it is possible to maintain social distancing requirements and for people to continue to protect themselves. But I'd also emphasise the importance for not just construction workers, people working in any environment, that it's not just what you do in the workplace, it's what you do during your break times, it's what you do when you're travelling to work, it's what you do when you go home. So the balance between personal responsibility and then the responsibility that applies to your employer is something that we all have to remember as individuals. It isn't just what somebody else will do for you, it's also about your own individual personal behaviour. But I do recognise that there are some either types of work or types of workplace that make it very challenging for some of the social distancing recommendations that we have made to be fully observed.
And just final one from me, the UK today, they've ordered, I think, around 3.5 or 4 million COVID-19 or coronavirus home testing kits, and they say that they'll be rolled out within the next week, where it's a 15-minute test at home. I think it's a finger prick, a blood test that you can do. Have we any plans, even for people out there who may not get tested through your system but would like to know if they have it or not, have we any plans that you could buy these in Ireland or be provided with a home testing kit?
So one of the things we're doing as part of the work of NEFIT is looking through the process of health technology assessment at possible new testing arrangements and new testing methodologies. And if we can identify something that we think has a role to play in helping to increase the reach of our testing and the way in which we test and make that more efficient, then we'll be seeking to try and procure and deploy those kinds of testing methodologies. We're very aware that there are a wide variety of serological tests and other forms of tests as candidate tests to add to our testing methodology. We'll be keen to adopt such technologies as soon as we possibly can. Yeah.
Just to could add to that, the serological testing based on our current expert advice from our own experts who are informed from international experts to the current test detects RNA from virus from people who are actively shedding the virus, and it's extremely sensitive in real time. The serological tests generally look for an antibody, which sometimes there's a lag time before that develops in significant quantities. So the current mode of testing, with all the difficulties that it entails, is a much more sensitive, and that's based on the current evidence, a much more sensitive test than the serological test. But of course, this is an evolving field, and it may be, as we've discussed, that more sensitive serological tests in real time may develop, and of course we'll consider them then.
Sorry, Peter Doyle, Irish Medical Times. I was just wondering, do you have any information or figures on the number of healthcare workers who are self-isolating at the moment? Not necessarily confirmed cases, but self-isolating as a result of coming into contact with a confirmed case or showing symptoms. Do you have any information on that at all?
I don't have that information. What I have is the information in relation to healthcare workers who are confirmed cases.
Yes.
The number of those who are self-isolating, some of whom could be doing so.
Yes, so you could have a situation where, you know, someone in the hospital, their spouse is a confirmed case, and so they have to stay at home. Is there any information on that at all?
So we don't track that information. So a confirmed case who might have a spouse or a household contact who is self-isolating who's a healthcare worker.
Yeah.
I don't have that information.
Will there be any plans to at all?
Unless it's within the HSE.
It would possibly on an individual hospital level, it's easier for us to collate that information because all the healthcare workers are all one. But there's a variety of reasons why people might be self-isolating. First, based on the advice they're given if they have respiratory symptoms, and secondly, if due to the contact tracing process, they've been advised to self-isolate. So they come under different categories, and we don't have one single way. But in each hospital, certainly in each clinical institution or entity would have a sound grip on what numbers are in isolation for one way or another, because it's obviously of immediate concern to their services and the continuity of their services.
So, so would you have any indication about the impact this virus will have on future staffing levels in hospitals? Is there any indication just now?
Well, clearly site by site, and we see from the trends that some hospitals are more affected than others, and so we are aware of the impact this has had from the very earliest stage when we had a patient in an intensive care setting in one major hospital. And that's one of the reasons why in an earlier stage the NEF made a decision to look at essential workers who are contacts and to see and to make specific advice as to how their follow-up might be different if all other methods were exhausted. So we are trying our very best to maintain essential services despite the imperative to isolate people who are contacts, but we're also recognising we need to maintain these services through special, if you like, special conditions applied to healthcare workers. But each hospital is working with us very closely in the HSE. We're aware of the service pressures in each hospital. At this point in time, we're maintaining all essential services, including ITU, including emergency departments. So none of our services have discontinued as a result to date. But as we all know, many of the non-emergency services have been curtailed on some specific sites.
Okay, thanks.
Okay. Could I just pick up on that? Are you satisfied that appropriate measures, I'm George Lee from RT, are you satisfied that there are appropriate measures in place, the measures that are in place are appropriate to protect healthcare workers on the front line? Are you satisfied that enough measures and appropriate measures are now in place, given that 25% of the people infected have been healthcare workers?
Well, clearly much of the focus has been on personal protective equipment, and we've been very open about the challenges we face in a global market, a very competitive global market with export restrictions in securing personal protective equipment. But the advice for healthcare workers goes way beyond personal protective equipment. It goes it extends into their own behaviours, the way they relate to each other, their own social distancing at work, and their own the imperative that they must act with great care at all times in those basic personal hygiene advice, and also in minimising the contact with affected patients. So we've been in close contact with all our clinical directors in hospitals. We've issued directives out to all our hospitals as to the appropriate use of personal protective equipment, and also where it should not be given advice as to what is inappropriate use, because we don't need to deplete our very valuable resources anymore. But we're not. There's no intent, and we certainly want to protect our staff, and we want to secure a steady supply of personal protective equipment, which we're hoping will begin to be shipped in from China this coming Sunday in large quantities. In the meantime, our hospital groups are working with each other to transfer personal protective equipment from site to site based on the greatest need. And we know, for example, in St James's Hospital today there was a shortage, and we then facilitated the delivery and transfer of equipment to their hospital to make sure their staff have all the safety equipment they need in dealing with the patients in that hospital. So there's transfer of equipment, there's us securing new shipments in from China, and there's advice to healthcare staff that goes beyond personal protective equipment, that goes into their behaviours and their own compliance with the advice they've been given so as to minimise their chance of infection and transmission of the virus.
So it's not 100% ideal. You're just tackling all these issues all the time.
We've been there's no doubt we face huge challenges in getting PPE, and I know in other countries they're running out of stock. We're fortunate. Last week we really were in a position where we couldn't be guaranteed to ourselves that we would get stock in, but further to this deal, which has now been secured, we're hoping from this coming Sunday we'll have, I'm talking about millions of respiratory masks, facial masks, long sleeve gowns, goggles, all that equipment we need will be coming in their millions through 50 to 60 airplane loads beginning, we hope, this coming Sunday from China.
Good stuff. Tony, can I come back to the change in the criteria for testing? You say it's the WHO criteria that you're embracing, but really you have gone much further than the WHO with the criteria in terms of groups, which is the thing which caused people confusion today. Or am I right? Like a temperature plus another symptom, but then you have to be in one of these 7 different categories, which are referred to as well in the letter to the GPs. You know, an at-risk person in your household, or you've got one of these a kidney problem or a heart disease, and so on, or maybe you're in prison, or maybe you're a smoker. All of those different things. They're not. Am I right in saying that they are not WHO specific recommendations?
So those prioritisation criteria are based on effectively the ECDC advice. But the position in relation to the case so the case definition is the set of symptoms. That's the tool, if you like, for the general practitioner to help them to come to a diagnosis, if you like, of a kind that is going to make it more likely that the individual has COVID. The prioritisation is particularly important where we at this stage have a constraint in terms of our capacity to deliver all of the testing that we would wish to deliver. We've been clear with you that although there's a testing capacity that runs at this point well ahead of many other countries, it's still not as great as we would like, and there's a plan to continue to grow that in the coming weeks to bring it up to something in the region of 15,000 tests per day. And continue to grow past that, but 15,000 per day over the second half of April. So that's our target. And in that time period, the purpose of the prioritisation criteria are to assist a GP in helping to identify the priorities that should be accorded in a situation whereby some people may have to wait longer for a test result than others. That's the purpose of the prioritisation criteria. But as Dr. Glynn said earlier, our clear strategy is to continue to try to identify as many cases as we possibly can through the case definition that we've got there, and then to contact trace those individuals. So the prioritisation criteria are just a way of helping us to ensure that if some people have to wait longer than others for test results, that the ones that come first in the list of priorities are the ones that are on that list. That's okay. What that is.
And as Dr. Glynn points out in the statement that we have received here, the written statement, it's short-term prioritisation. You plan, or you may well have to change that again.
So throughout the process over the past number of months, we've had to look at the case definition on an ongoing basis. We've looked at prioritisation criteria on an ongoing basis. And as I said, yes, clearly our stated plan and aim is to continue to increase our testing capacity over the next few weeks. And obviously, as that capacity increases, the criteria will change and differ, and more people will be tested. That's our objective.
Okay.
And in as quick as a time as is possible.
Okay. The other thing, Tony, when I looked through the changes announced today and the letter which you communicated to the GPs through the various channels, it said that the people who did not have an appointment, that those people would have to be re-triaged by the doctor. Do you have an estimate for how many people that would be? Because if there was a backlog of 40,000 for testing, which is enormous, how many of them did not already have an appointment? Do we have an idea?
We know, as we said last night, that there was certainly on some days there was the order of 15,000 or so people referred for testing. And we know also, as we've said, that these symptoms were non-specific and not focused enough. So clearly, as to what proportion of the people who are waiting will have both a temperature and a new symptom and be one of the priority groups, it's hard to say. It'll be a much more narrowed focus group, but it'll certainly be a much smaller subset of the quantity of people who are waiting for testing.
But many of them, even who wouldn't, they will discuss it with their doctor again, no doubt. They will ring back the doctor.
Yes.
It'll be a reconsultation. It will be a renewed fee, even if they're not put forward. So it's a lot of extra money. It's a lot of extra consultation.
It may be, but it's the right thing to do, because clearly we need to focus on these groups, because they're the highest risk group. It's the highest risk group in terms of the body of work that's in front of us. And that's the purpose of the whole public health strategy, to identify the most at-risk cases, to carry out surveillance on these most at-risk cases, to avoid the most dangerous scenarios for dissemination of the virus. So that's why the focus brings a greater, it throws our resources at the right people, at the right groups. So yes, it's more work. Yes, it may involve more money, but it's the right thing to do.
Okay.
But I would just, if I could just add, George, to encourage you to not focus just on the testing, not because it's uncomfortable from our point of view. We've been clear, we've been honest, we've been open about the impact that this has had. The large number of people who have come forward seeking testing is way beyond our capacity to test. It's way beyond the number that is necessary for the management of this disease. It's not feasible, it's not a good use of our resources. It caused us to have to change the case definition to limit it more. We'd like to say that we'd be in a position to have tested every single person who came forward if that was a number that was manageable or necessary. And it hasn't been. And it's required us to make changes of the kind that we've now made. We've worked with the colleges, with the IMO and the general practitioner community to effectively communicate the message to them about what that means when they are consulted by patients with these kinds of symptoms. So the message to the public is still the same. Your GP knows now how to decide to manage your illness, and to consult and engage with your GP if you have symptoms, to stay at home and self-isolate, because that is the key measure. It's not the test. The test is a public health test. It's not a clinical test to tell you something about the treatment for your individual illness. Yeah. The key measure for you, if you have these symptoms, is to stay at home and self-isolate for 14 days and to restrict the movement of your household contacts. That's the thing we want to emphasise. Okay. And as we move forward, we will grow our testing capacity. We will test many, many more people, because that still remains our policy and our intention. And we will have to, over the course of the next number of weeks, grow our testing capacity by getting more swabs in, by increasing the number of tests that are done in the sampling centres, and by increasing the capacity in our laboratories to get us to a point of 15,000 or so tests per day, which is our target at this moment in time, well ahead of many other countries in the world.
Okay, and that having been understood and appreciated, still on the testing issue, because there was a big point about that to change your testing criteria. I know you do it more than once, but one of the issues was 6% of tests turned out to be positive, which looks like an awful lot of wasted tests. So you've changed. So do you have a target? What would you like to see as a percentage in terms of positive, up from 6%?
If one of the other figures I might give you, which I haven't given you before, we don't have a final figure for this week, our influenza-like illness rate, which is the number that comes to us through the sentinel surveillance system that we use across general practice. There are 61 sites and a number of GPs reporting these kinds of symptoms. They have seen, we know, a very significant increase in that rate over the course of the last week. So it was about 15 per 100,000 last week, and the rate now is many orders of magnitude bigger than that. We won't have a final figure for that, I believe, until tomorrow to confirm to you. And that's in a context where the positivity rate is 6%. So there's been a very significant increase in the reporting of influenza-like symptoms. But it's clear that that's not been in response to a change in disease pattern. Usually when you see an impact like that in a spike of the influenza-like illness rate, it is accompanied by a significant increase in the percentage of positive cases in the population in an influenza season. So as your influenza rate goes up, your positivity rate goes up, showing you that the disease is the thing that's driving the increase in the ILI. We can see with the 6%, it hasn't been the disease that's been driving that, it's other behaviours, which again reinforces our view that the broad case definition that we had was leading to a lot of worry. It was a lot of help-seeking behaviour on the part of people who probably did not have COVID or were never likely to have. And as I've said to you, was well in excess of what we needed, both for the public health management of this or anything that would represent a reasonable use of our resources or targeting of our resources in the context of our collective response to this illness.
So does that mean you don't have a target for 6% plus? You want it better than 6%?
It's not so much a target, but what would usually happen, say, in a flu season, when you would get to the peak of the flu season, the positivity rate might be something in the order of 40-50%, which would mean that for every
test you're doing.
Yeah, for every test that you were doing, about 50% of them or so were turning out to be positive. And that's what would be the usual pattern when you've got a spike of illness caused by a change in the disease in the population. We've seen a spike in test requesting, but not accompanied by a change in that percentage of the kind that we would see in a flu season.
Okay. And one of the other, and you may have, Dr. Henry may have touched on this answer, but I need to ask you anyway.
Sure.
For my own information. In the UK yesterday, they made a big point of the fact that they'd ordered 3 million kits for testing people for antibodies to encourage so they know when people can go back to work. Do we have any idea or any notions along the same lines? Because there are a lot of people who would probably like to go back to work, wouldn't like to be off for many weeks, would like to know if they had antibodies. There are a lot of people who aren't being tested who may kind of have already had this disease. As they said in the north, they figure there's thousands rather than hundreds. So have you any plans to start to order, like they have in the UK, significant number of antibody tests as part of the overall strategy?
So we want to be in a situation where we have a reliable serological test that we can use for a variety of purposes, including the purpose that you've identified. We're not at a point yet where we've identified a test that we think can be used in this country in the way that you're describing.
You would not be satisfied with the UK, what they're buying, that test?
I'm not going to criticise the UK. I'm simply going to say that we haven't been satisfied yet that that's a step that we're ready to take. There have been significant differences in policy here around testing of our population, around public health recommendations to the population as between here and the UK. We think we're following the right strategy now in terms of focusing our testing on identifying confirmed cases of this illness and instituting control measures and contact tracing measures in the population. Those are measures which are not currently part of the strategy in the UK, and they've moved to a different testing regime in terms of serological testing, near patient testing kits. We don't think we're ready for that step at this point. We want to focus our efforts on the public health containment measures that we now have in place in the population.
Thank you.
Paul Cullen, Irish Times. Quick question first. Just to clarify, if I have one symptom, I'm not going to be sent for testing, but say I have a new cough, should I be self-isolating for 2 weeks?
So we would say yes, that the responsible thing for you to do is if you have symptoms that of an illness that can be transmitted to somebody else, we think the right thing for you to do is to restrict your movements.
Isolate?
Yes.
Or restrict?
Yes.
Okay. We've seen figures, modelling figures for the expected number of cases and so on in the coming weeks. What are the equivalent figures for ICU admissions?
So we haven't done forecasting figures for ICU. The number of cases that we have of ICU has continued to increase day on day, but we haven't projected that forward into a set of data that project us to a point where we'd say we think we will have X by by the end of next week or Y by the end of the week after that. That's something we're going to be looking at in the coming days. We meet again with our National Public Health Emergency Team in the morning. That's one of the questions that we'll be looking at.
And what's your feeling? We've probably doubled our capacity. Is it still around that, maybe with the various addition of capacity over the last while? How are we equipped now to cope with the expected surge?
Colin, do you want to-
Yes, Paul, we have been anticipating, to just add to what Tony says, we know from international experience what happens in unmitigated situations where there's no control measures, no countermeasures, and no social distancing and no extensive testing. So fortunately, we've got ahead of that in this country. So, and as yet, there's no sign of a huge surge in ITU admissions, despite increased activity. But in anticipation of what may happen, despite all our efforts, we have been expanding our critical care capacity, looking at all HDU, high dependency settings being converted to ITU beds, looking at private hospital facilities too. And our baseline, if you like, ITU capacity would have been in the order of 220 or thereabouts. We've built on that, and we anticipate that we'll be approaching 500 at least as a baseline to include all private facilities. And that doesn't include a potential provision of intensive care type care outside ITU settings in anaesthetic rooms and recovery rooms and so on, and hence the measures we've taken to purchase additional ventilatory equipment should that be needed. So we have made extensive preparations in the HSE for expansion, not just of ITU facility, but expansion of ventilatory capacity too.
Okay, and one other question. I'm trying to understand how patients are going to be allocated when the surge comes. Are you envisaging COVID-19 type hospitals and non-COVID type, or other hospitals for non-COVID-19 patients, the regular ones? Are you going to separate them all? And if so, what will be the lines? You know, will it be in private, public, the old private, public, or new hospital, old hospital?
Given the nature of this, of the illness and dissemination of the virus, and in a country such as, if we were a densely packed population living predominantly in single urban areas, it would be easier for us to designate hospitals as COVID-19 only hospitals. There is a case for this has been made in other countries where there's been, such as Italy. In our own situation, based on our hospital groups and based on the configuration of our hospitals, it's very hard to designate a hospital in the Síolta Hospital, for example, a designated hospital where the group extends as far north as Letterkenny and as far south as Galway. So within hospitals, there's two measures here. One is to designate COVID-19 hospitals. The other is to designate COVID-19 wards and segregated areas within hospitals, which perhaps is more realistic for our healthcare system. And so we're pursuing that particular method with our own hospitals at the moment in segregating of COVID-19 patients as much as we can within the hospitals into which cases are coming, but also looking at designated hospitals within urban areas, which are self-selecting in Limerick or Cork, for example.
So which ones will they be, sorry?
Well, those plans are ongoing with our acute hospital system, so at this point in time, we're predominantly focusing on segregated areas within hospitals.
So, but you will have designated COVID-19 only hospitals, but you haven't decided those?
No specific plans as yet. As I said, it's very difficult within our geographical dispersion to have that.
Even in Dublin?
Yeah.
So there is going to be some consideration of that question in the morning, which is not to signal one way or the other what we're going to do. At our Public Health Emergency Team meeting, we are giving consideration to that as a possibility, as we do on a continuing basis. So I don't think there's a final decision made as to what hospitals, what cities, what locations, but I think...
Thanks.
Yeah.
Just want to follow up on something which Richard Boyd Barrett gave out after his briefing with the HSE earlier. He said that the HSE admitted that the possibility that people who have had COVID-19, who haven't been given their test, they've been waiting for their test, may have had COVID-19 and now don't, they've been through it. Is there any concern in that regard then for people who might have not been identified and passed it on to a number of different contacts? From a contact tracing point of view, that people have now recovered fully from COVID-19 without ever knowing that they actually had it?
I mean, that'll be the case for a variety of reasons, not just the reason that you identify. although our efforts are to try and detect as many cases as possible, we're not saying to you that we think we've done that and that we'll continue to get the message out as much as possible. There will be cases in the population that have escaped detection, if you like, for various reasons, either because the symptoms are mild or even for some of the reasons that you've identified. And the reality is that might be why arising in the population we have 49% of cases occurring where we can't track or identify the source of infection for those particular individuals. So there will be cases in the population that arise in that way, that pass on the infection without ever knowing that they had COVID-19, and that then gives rise to a diagnosis that for us is leaving us questioning where did this particular individual come from. We think the likelihood of that is significantly decreased in a situation whereby we direct our testing strategy in the way that we do, our public health messaging in the way that we do, and we emphasise for people as strongly as we possibly can that if you have these symptoms, you self-isolate for 14 days, you consult your GP. Your GP will make an assessment as to whether you meet the case definition or not. We'll arrange for testing if that is necessary. And if you have household contacts, that your household contacts self-isolate with you. And now, unlike the earlier stages of this whole illness, that's not as big an ask of people as it was, because we've made already a big ask in terms of social isolation of people to restrict very substantially their social activities, to work from home where possible. We've cancelled many of the kinds of things that people would spend their leisure activities on. So asking people who are contacts to self-isolate along with suspected cases in the community, we think is something that we expect a high degree of compliance with. And that's our key public health message. Shane.
Just one very brief question. You said that NEFID's meeting tomorrow morning. What are you considering tomorrow?
So we have a standing agenda, which is a pretty standard structure. It has evolved and changed over time and so on. So we'll do the usual examination of what is happening here in terms of infection, looking at what's happening internationally, considering any new guidance. You may be aware that the ECDC has published new risk assessment today, number 7, I think, in the series of risk assessments that it produces. And we'll give consideration to all of those things. We'll look at the situation in a variety of other countries and what's happening there. We'll look again at the existing measures that we have in place and review what we think about those, review the data that we have, give consideration to any further measures that might arise, not that we're necessarily thinking of using this, but to continue to ask ourselves what further could be done in the event that we needed to do something, and that's all part of appropriate preparedness. And we want to give some consideration to some more specific things. We'll be giving some, I think, early consideration and discussion to the whole question of research. We think research in this country will have a contribution to make to understanding the impact of this disease, not just in terms of the technical, virological and treatment issues that are obvious, but also perhaps in terms of some of the other impacts that arise for society of the social distancing measures that we have in place. So a pretty broad agenda of things as we always do.
Okay, thank you very much.
Yeah.